Good evening, everyone. Welcome to the Group Insurance Commission Public Information Session for Benefit Plan Year, July 1st, 2021 to June 30th, 2022. My name is Matthew Vino. I'm the Executive Director of the Group Insurance Commission, and we are grateful for your attendance here this evening. This is the first of 4 public information sessions that we will be holding this week. And as many of you will know, the GIC holds these sessions every year as part of our process to finalize plan design and premium rates for health insurance plans that will be offered during the coming annual enrollment period that begins in April. We typically hold these sessions across the state, live in person, but this year, of course, due to the governor's emergency measures to keep people healthy and safe during the time of COVID-19, we are holding these sessions virtually by Zoom. We are also live streaming the session on YouTube and will subsequently post the entire session on YouTube. Our plan this evening is to do a presentation of about 30 minutes, followed by a virtual question and answer period. I'll also be joined in the presentation by my colleague Denise Donnelly, a key member of my leadership team here at GIC, who works on benefit procurement and a number of other items. And I will also be joined by a number of senior staff at the GIC when we get to the question and answer period to assist in accurate responses to your questions. I have 2 housekeeping items to just start off with. And first is to note, as it says at the bottom of this introductory slide, that this session is not required for anyone who is participating in annual enrollment this year. This is completely voluntary and informational only. We will also have, as part of this presentation, closed caption. So I would, for those who want to avail themselves of that option, you will find a link in either the chat or the Q&A function of Zoom. So we will be posting that link there. And on our session on Wednesday, we will have a sign language interpreter for those that need those services. A few more housekeeping items will come up in a moment, but go to the next slide, please, and we'll look at our agenda for this evening. So we will start this evening with a brief overview of the Group Insurance Commission. Many of you will be very familiar with the work that we do and who we are, so we won't spend a whole lot of time on that. But in addition to just a brief overview of the agency, we will touch on a number of the challenges that we face as we're delivering on our mission to you, our members, especially as it relates to healthcare benefits that we provide to you. Then we'll provide some information about health insurance premium rates for your plans starting on July 1st of this year, which we are in the process of developing now, but we have not yet finished. And one minor but important change to plan design. And for those of you looking for the key takeaway right at the outset, I will give it to you right up front. The GIC is planning no increases in copays or deductibles for members for the coming plan year. There will be also no changes to our retiree plan through Medicare. I will note, and we'll get to this a little bit later, there may well be some changes that come from the federal government for Medicare, but we are not making changes. Then we'll be looking a little further down the road to beyond this coming year and describe how we at the GIC are preparing for the next big set of decisions regarding health benefits, and this will be for coverage starting on July 1st, 2023. So we will give you a brief presentation of our health benefit procurement process, and then we will leave plenty of time at the end to respond to questions and comments that we have received in advance of this session, but also those that are submitted under the Q&A section. So A few more of the housekeeping details. Next slide, please. So we are this evening specifically seeking input on premium rates, health insurance plan design for the coming benefit year, and our ongoing engagement strategy that will continue beyond this year. Our initial plan, of course, was to be able to provide verbal testimony as part of this Zoom webinar, but due to the overwhelming number of people who have registered, we've had to adjust the format. You may submit questions at any time during the presentation, including now, using the Q&A tab on your Zoom application, which is typically at the bottom of your Zoom screen. We will be reviewing those questions real time throughout the session, and we'll be prepared to answer them at the end of the presentation. With such a large number of participants, of course, we may not be able to get to every question, but we will take everything that we hear tonight and in the subsequent information sessions, and we will do three things. Number one, we will create a frequently asked questions and FAQ document. We will also produce a comprehensive report of everything that we've learned during these sessions, and we'll be providing a summary report to our commission members at our next meeting on February the 11th. All of these documents we will post on the GIC website where you may view those. I also want to note that for those of you who wish to, rather than pose a question, would like to make a statement or a lengthy statement, we strongly encourage you to send us in written comments at the address listed on this slide, gic.info@mass.gov. Again, all of this information you can find on the GIC's website. Also, finally, if you have questions in the question and answer period that are specific to your coverage, including personal details, I encourage you instead to contact our operations team directly for assistance so that we may help you but protect your privacy. Next slide. So the first section here will be a brief overview of the Group Insurance Commission. Next slide, please. And of course, we start with our mission, and it's a pretty simple and straightforward mission. I do want to highlight just a few words that are particularly important to us and that stand out to me. One, of course, is in the middle of that top line, and it's our members, it's you. And you are and always will be at the heart of everything that we do here. I, for one, hold on to this sometimes feels old-fashioned notion that public service in any capacity is a really honorable calling, and you deserve the benefits that you can count on. So we honor that service, and we are here to serve you. In fact, we serve with you, the 75 employees of the GIC and myself as state employees. The second thing I would note from this slide is the focus on high quality and affordable benefits in the middle of the second line. And this notes that we are focused on balancing two really important objectives. One is providing you with comprehensive, high quality benefits. But number two, we need to do so in a way that is at a cost that you can afford, and those who assist in paying premium, that being the Commonwealth and our municipal partners and other partners in government. So ultimately, it needs to be affordable to you and the taxpayers for this to all work. Next slide, please. So to achieve that mission, the GIC has identified three core strategies, and I'll start in the middle here, managing for value. So we aim to design and make available to you all a meaningful choice of insurance options and benefits to provide the best value to you. Second, on the left, we aim to provide you with modern tools to make those best possible decisions so that they meet your insurance needs. And then interacting with the GIC really should not be a hassle, right? It should be as easy to use as all of the online tools that we are all now much more accustomed to in purchasing any sorts of goods or services. And then number 3 on the far right, modernizing the GIC. This is really important. In order for us to do those other 2 things effectively, we need to have the modern tools ourselves as a staff. And I'm glad to say that we are making some very significant strides in that area with much more to come. Next slide. So some key additional facts about the Group Insurance Commission. We have 462,000 total members, of which 110,000 are Medicare subscribers, retirees. This, of course, makes us the largest purchaser of healthcare in the Commonwealth of Massachusetts, with a total budget of $2.1 billion. As you'll note in the bottom left, we are governed by a 17-member board of commissioners. I'll say a little bit more about them in a moment. We also have 918 partners in government at the state, regional, and municipal level. And we work very close with them every day. Next slide, please. So I want to acknowledge the highly talented members of our commission who, as you can see, represent a wide range of interests, expertise, and background. These are my 17 bosses, and we meet roughly every month to make all the key decisions that we need to make to provide you benefits. This evening, I do want to acknowledge 5 members of our commission who have joined us here this evening as participants. Bobby Kaplan, representing the National Association of Government Employees, NAGE, who also serves as the vice chair of the commission. Christy Kleinert is a public member, appointed member by the governor. Also Toby Choate, another public member appointed by the governor. And finally, Tim Sullivan, representing the Mass Teachers Association. They are all extremely helpful to me and provide good counsel and guidance to the commission. So thank you. Next slide. So, I'm sorry. I think I neglected to mention one other member of the commission who's joined us, which is Rebecca Butler from the Division of Insurance, who is a designee of Commissioner Gary Anderson. So thank you, Rebecca, as well. So the GIC 101, these are, this will be familiar to all of you. These are the services that we offer to you: health, dental, vision, life, long-term disability. We provide flexible spending accounts for healthcare and dependent care, and offer an employee assistance program, which many of you will know by the name of Mass for You. So it covers a wide range of benefits, many of which were legislatively mandated to offer, but we do so to bring benefit to you. Next slide. So the GIC is funded by a number of sources, primarily the Commonwealth of Massachusetts, that provides a substantial outlay in support of premiums. In addition, our individual members also contribute a portion through your paycheck and through your pension check. In addition, we have municipal cities and towns that also contribute to premium, and that totals up our $2.1 billion per year. Next slide, please. So the way GIC health benefits are financed, without getting too much into the weeds here, is a little different than what many of us may be used to. The GIC is a self-funded plan sponsor, which means that the GIC and the Commonwealth of Massachusetts ultimately holds the insurance risk and not the insurance company that you are enrolled in. So when you as a member receive healthcare services, your doctor then submits a bill to your health insurance company, which then reimburses the provider, the doctor who provides you that service. Those insurance companies in turn bill the GIC on a weekly basis, and the GIC reimburses those carriers for those expenses. So if over the course of a year, members use more healthcare services than is expected, then the Commonwealth of Massachusetts actually pays that extra amount. You, as the member, do not. And if members use fewer healthcare services than expected in a given year, the Commonwealth spends less, but members in turn do not in terms of premium. And if we look over the last 10 years, it's actually been pretty evenly split. Some years the Commonwealth has needed to cover that entire additional expense, sometime to the tune of $100 million or more. And then there have been times when the Commonwealth has paid less than expected. But this is generally how self-insured insurance works. And I thought it was important to sort of lay out that basic framework. Next slide. So the challenges that we face at the GIC in delivering on our mission are not unique to us. They are the challenges that everyone faces here in Massachusetts. I could easily spend an hour going into depth on each of the boxes on this slide, but allow me to just pull out a couple of salient points. We have to start, of course, in the upper left. Healthcare costs are not sustainable, and they are growing. They continue to grow in Massachusetts as elsewhere. This is true for people with private insurance, and it is true for those with GIC insurance. After a few years recently of no increases and then some small increases, we are now starting to see healthcare costs and therefore premiums rise again. And that is something that we pay very close attention to and are concerned about. This is no small thing for taxpayers and for members, many of whom, especially retirees, are on fixed incomes. I note here that is a data point that often sticks with me regarding fixed incomes for those on a pension. We looked today and checked the average pension benefit for a retired teacher is somewhere in the range of $42,000 to $45,000 a year. So we keep that type of a number forefront in our mind as we grapple with the healthcare costs, knowing the burden that it brings to you all. Secondly, it's hard to pick up the paper these days and not read about some big hospital that's buying another smaller hospital. Evidence of those sorts of mergers and acquisitions indicate that they don't typically produce savings, but instead drive up costs. We have large, well-known hospital systems that get bigger, they gain more market power, and they increase their prices that are already quite high. Now, the GIC has an opportunity to use our purchasing power to push back on that, but we as an agency have historically divided up that power between half a dozen insurance companies or so, and that serves to dilute our ability to really push back on that growing market power that leads to higher prices from hospitals and doctors. Finally, health insurance coverage seems to get more complex and more confusing every year. We go to the doctor, we use our insurance thinking that the cost is covered, only to find that we get a big bill in the mail from our doctor and we don't understand why. The GIC has tried also to design plans that provide lower cost sharing when seeking services at a lower cost, but equally high quality hospital or doctor. Yet we find that our consumers don't respond to those financial incentives, yet instead continue to seek services at those high cost providers, which leads them to have incur up to a $1,500 copay, and in turn also increases premiums for all that pay premiums to the GIC. So these challenges are real. They are the ones that we need to balance as we seek to accomplish our mission and provide you quality, affordable benefits. At this point, I'm going to turn over the presentation to my colleague, Denise Donnelly, who will walk through the next section of the presentation on premiums. Denise?
Thanks very much, Matt. Hello, everyone. If I could see the next slide, please. And the one after that. There we go. And you can run that all the way through the animation. Thanks, Erica. So this is the process that the GIC follows every year in setting premiums for the upcoming fiscal year. So let me go back and explain what we did back in December when we met with the Commission on December 17th. At that point in time, we presented what we call preliminary pricing. And we call that status quo pricing because it means that what would the premiums be for our plans if we had no changes to health carriers, to plan options, to plan design, and no movement of members among the plans, and no change in the way members are using their care. So that's status quo pricing we presented to the Commission in December, and that was really an aggregate number, and I'll share that with you in a moment. Then last week, we met with the Commission to share proposed plan design changes with the aggregate financial impact of what those plan design changes would mean. And as Matt said earlier, we're really only proposing one small plan design change this year that the Commission will then vote on in the February 11th meeting coming up. And so we take what we learned from the January meeting, we present that to the Commission in February for a vote. And once we get that vote from the Commission, we then are able to move forward and develop product-specific premiums for individual and family coverage for each plan. So that's where we are in the timeline. That's the process that we follow. And the Commission will be voting on March 4th as to what the fiscal year 22 product-specific premiums will be. Next slide, please. So let's take this slide slowly because there's a lot here and it's not always very clear what we mean by aggregate premium increase. So first of all, this is assuming no plan design changes. And what our actuaries found in examining our experience over the past period of time is that we are expecting an aggregate average premium increase of about 5.8%, with the low end aggregate expected increase of maybe 4% and a high end of 7%. Now, what that means is not that your plan premium is going up by 5.8 or 7 or 4. What it means is overall, for all of the non-Medicare and Medicare plans that the GIC sponsors, the average aggregate increase is expected to be in that range, most likely around 5.8%. You'll also see a notation above the spectrum arrow there referencing the market. So that's the general healthcare marketplace in Massachusetts. And we're seeing those premium increases ranging from 5 to 7%. So the GIC is within the market range of what is going on generally in healthcare costs. Next slide, please. So once the Commission votes on premiums and we make our way through that process, annual enrollment will begin on April 7th and close on May 5th of 2021. Matt?
Thank you, Denise. So the next section of the presentation is about plan design. Next slide, please. So here I'll start where I noted at the very beginning of the presentation. The GIC staff recommended to our Commission last week, and the Commission agreed that we should make no changes to health insurance plan design for the coming year that increases cost sharing to members. As it notes here, we do generally prefer not to make changes when we are in the midst of our typically 5-year contracts with our health plans, as they tend to be disruptive to members. And this is a concern, of course, that is only heightened in the context of the pandemic. So we felt that this was really not the time to be making those sorts of changes. I will also note, as the bottom bullet here says, that we are also not making changes to any of our Medicare supplement plans, though as I noted at the outset, it is possible that the federal government makes changes to Medicare, basic Medicare, that could affect members. So keep an eye out for that. Next slide. So you'll see here, this is the list of all 6 carriers and 11 health plans that we offer today. And we are not making any changes here for the coming benefit year. All 6 plans and all 11 products will be offered in the coming annual enrollment. Next slide. On that topic, I thought it might be helpful just to note here, as many have likely heard, Tufts Health Plan and Harvard Pilgrim Healthcare recently announced that they have joined into one combined organization. A number of you may have questions about that. I want you to know that as executive director, I am in regular communication with the CEOs of both companies and have expressed our strong interest that there be as little disruption to our members as possible as a result of this transaction. And they both expressed to me that they share that important goal. You may read in the coming months that they announce a new name for the company, the combined company, but I want to assure you all that they will both continue to operate as separate companies for some time. So if you are currently covered under either Harvard Pilgrim or Tufts, there will be no immediate change to your policy, and you should continue using your current member ID card. Furthermore, for this coming annual enrollment, members will be able to maintain their enrollment or newly enroll in either one of these plans. That is also true for the subsequent year's annual enrollment. So this year, you will have both options, and next year's annual enrollment, you will continue to have both options. Members will be interested to follow along here and gather more information. This combined entity, Harvard Pilgrim and Tufts Health Plan, have provided information that is available to you at the link that we note here. But I would also encourage folks to continue to watch the GIC website for further information. Next slide. So there's only one relatively minor change to plans that we have recommended to our commission, which we did last week. You will note that it is not an increase in co-payments, it is actually a decrease. The proposal is to provide for each year 3 behavioral health office visits delivered by telehealth at no cost to you, our members, no copays. Furthermore, this does not replace the 3 free visits that are available currently and will continue to be available through Mass4U. That will continue. We see this as a really important way to expand access to behavioral health services, particularly in a time dominated by COVID, and particularly at a time when capacity and access to those services is constrained. We know that behavioral health conditions during this time can be especially acute, so we want to be able to meet your needs. So this is not the year for big plan design changes, but this is one in which we wanted to provide some additional benefit to you. Before I move on from this slide, though, I do want to note that one of the things that we know is that changes to copays and deductibles, it's a very blunt instrument, and it doesn't, with a whole lot of success, reduce premiums all that much, especially when compared to the friction that they create for you, our members. However, as I noted earlier, the rising cost of care that is driving up our premiums is unsustainable for everyone. So we need to address that issue. And on that note, I will turn it back to my colleague, Denise Donnelly, to talk about the process that we'll be using and focusing on to get at that those underlying cost drivers, and that is procurement. Denise?
Yeah, thank you, Matt. Next slide, please. And the one after that. So before I explain the process of conducting the procurement that we will be conducting in the coming 2 years. Let me explain what we mean by procurement. So it's the process by which the Commonwealth typically uses to contract with companies to perform state-related work. It's a process that's very strictly governed by mass law with an emphasis on ethics and transparency. And it's a process that GIC uses to select health insurance plans and other types of insurance companies to provide coverage, usually for a period of time of 3 to 5 years. And the contracts generally run 3 years with 2 one-year options to renew. So that's the underlying basis on which we conduct procurements. Next slide, please. So we're right now in year 3 of a 5-year contract cycle, and we're gearing up to conduct the procurement that will take us to wherever we're going to land on July 1st, 2023. And there are no decisions that have been made. We don't know what that's going to look like at this point in time. But what we are going to be doing is spending the next period of time listening, as we hope to do tonight, learning from our members and other stakeholders as to what considerations we should be taking into account as we do conduct that procurement. The process will then begin. We'll release a request for proposal, and you'll have the opportunity, as you do every year, to participate in annual enrollment in early 2023 for coverage that will take effect on July 1st, 2023. Next slide, please. And as Matt outlined earlier, our goal in the procurement is to really try to address some of these, the many challenges that we are hoping to address through that process that he described earlier. Next slide. So our goal with this procurement is anchored in our mission, which Matt set out at the beginning. We really want to design a program that is going to give you easy to understand, meaningful, and affordable choices. And by affordable, I mean affordable in the context of the Massachusetts healthcare marketplace. Simplifies the experience and the products available to you as members. So right now we have lots of products that are very similar to one another. And it's not always easy to figure out which one you should choose. That by the time we arrive at that, so whatever solution we arrive at, that people understand that it's the best possible solution we can arrive at as an entity, as an agency, looking to serve our members. Next slide. Matt, I'll turn it back over to you.
Great. Thank you, Denise. So key to our success in the process that Denise described, of course, is engaging with all of our stakeholders. So we need to start by listening to and learning from a variety of sources. And when we do that, of course, we start with our members. So that's why we're here today. And there will be more opportunities for us to listen to you in the months and years ahead. We will also learn from our colleagues in state government, both in the legislature and the executive branch, as well as our partners in local government and regional government. Many of you are also members of labor unions that represent you, and we have been and will continue to be in touch with many of them to understand their priorities representing you. The more we learn and understand, the better decisions we will come up with as part of the next procurement. That is why your participation here this evening is so important. One more slide, just with some information before we go to the Q&A section. So I just want to again remind viewers that those that have lots of questions, some of which we'll get to here tonight, some of which we've touched on, please visit the Group Insurance Commission's website noted on the slide here. We have provided information about a number of these items, and we'll continue to populate that and update it with new information. And on to the next slide. So this is where we will begin the public Q&A. So thank you for your patience as we walk through that presentation. As I noted earlier on, we have received a number of questions in advance of this session, in addition to a number that I'm sure have come up on the Q&A panel. And I am going to look to my colleague, Erica Schabelli, my Deputy Executive Director, to indicate which questions we should proceed with here.
Hi, Matt. So I have a couple of questions, more than a couple of questions that have already come in. The first one, a few that had been emailed to us in advance. So the first is, can an individual or spouse rate be an option for this and future open annual enrollments? So just a little more context there. They'd like to see an option for individual and / spouse as a monthly GIC product rate, rather than the family rate.
Very good question. This is not an uncommon feature of insurance plans that are offered in the private market. This is the type of question that we would address through the procurement, and not necessarily in a time right now where we are making only modest changes in the middle of our contracts with our current health plans. It is an issue that that is on our radar. I will say that this would indeed, as noted, provide an option that is more tailored to a certain category of our membership. However, it would also likely have the impact of raising premiums for those who would stay with a family plan. So that's the sort of thing that we'd want to consider very carefully, how it impacts different elements of our membership. I'd ask any of my colleagues if they want to add anything to that. If not, I'll go to the next question.
So the next question, and you touched on this a little bit, is what will the new coverage look like that will take effect on July 1st, 2023? And I think that's something Denise touched on a bit.
Yeah, and so we don't know yet. And part of that reason, as Denise noted, is that we want to take the time to learn and hear from you all, and engage with those various stakeholders that I mentioned. I want to, that will help us make a much better decision that meets your needs. And so we want to take the time to do that and to do it right. So what Denise said is absolutely true. We have not decided on anything yet. So we're interested to learn more about what your desires are. Thank you.
Thanks, Matt. We have a question. Is the GIC looking into a Medicare buyback program for non-Medicare retirees?
So this, we are aware, is actually, this is an idea that was presented to us from Mass Retirees representing our retired members. And we are evaluating that closely. We are aware that some municipalities have worked with a health plan to offer this sort of option or this sort of a transition for non-Medicare retirees. We are looking at what a number of other states have done. They are in a different position or have structured their benefits a little bit differently than we do. So we are learning as much as we can here and trying to figure out if there's a path forward that has sort of a sustainable price tag attached to it. So this is definitely something that is on our radar, and we will continue to work on and work with Mass Retirees on. Okay.
So the next question I've got is, the GIC has 462,000 members and is the single largest purchaser of health insurance in the Commonwealth. Why are our rates so high?
It's a great question. Of course, I wish I had a simple answer. It is a complicated answer. I think the first reason the rates are high is that we live in Massachusetts and we have among the most expensive healthcare in the country, in the world, in fact. So premiums reflect the underlying cost of care, which here is extremely high. And of course, there are others that we will work with in state government and partners at groups like the Health Policy Commission that will continue to try to develop strategies to get at those underlying drivers. Another reason that our costs are high is that our members tend to use more expensive hospitals and doctors. And we have very expensive hospitals and doctors, particularly in the greater Boston area. I would say, thirdly, that as I noted in the challenges slide earlier in the deck, that we have, as a result of our strategy of having 6 carriers and 11 plans, we've somewhat diluted our ability to maximize our negotiating, not negotiating as we don't negotiate, it's really our plans that negotiate, but maximize our purchasing power as the Group Insurance Commission. Instead of a block of 462,000 members, we've sprinkled them up among 6 different health plans, each with a lot less power than we would have as a purchaser, acting as one unified purchaser. So there are some dynamics there that we need to continue to grapple with. Lastly, I'd say that, and we monitor this quite closely, we do tend to have richer coverage through the GIC than you see typically in our peer organizations in other states, and when compared to the Massachusetts marketplace. When I say richer coverage, more is covered by the premium and less is covered by your copays and deductibles. It may not feel that way. And, you know, we can compare that to other benchmarks, but it doesn't change the fact of how it feels to you as a consumer of healthcare. But the fact is that we have more covered under premium than we do under cost sharing than other purchasers do have. Those are ones that are sort of top of mind for me. If others of my team want to weigh in, I'm happy to have them do so.
I think perhaps Cameron had something to add.
Hi, this is Cameron McBean. I work directly under Denise here at the GIC. With a little bit of the background context with that previous question, it's important to keep in mind that private employers have incredible amounts of discretion as to just how much of the cost of their medical insurance they wish to share with their employees. So there are certain industries, biotech, some IT functions, historically energy and engineering companies tend to have very rich benefit plans that are very low cost for their employees, but that is completely at their discretion as both the employer and plan sponsor, whereas the GIC works under a legislative mandate where the premium costs are shared for active employees on either a 10 to 25% share of the monthly premium, depending on your date of hire. That's the only point I wanted to make. Thank you.
Thank you, Cameron. Just another illustration of how we keep a very close eye on other healthcare markets here in Massachusetts and how we compare. Thank you for that.
Thank you.
Okay.
So the next question we've got is, has the GIC considered negotiating with more than one prescription drug plan to increase competition with drug pricing, larger formularies, and more importantly, choice for enrollees?
I would say that this clearly would be one of those strategies that we would employ again through the next procurement and not do off cycle. I will note that having choice of a so we do have two PBMs. We have two pharmacy benefit managers today. We have one for our active employees through Express Scripts, and one for our retirees through CVS. So we have two vendors, but we don't have an option there. What I would say is that the caution I would note again is that adding an element of choice here could further dilute again that market leverage that I referred to earlier. Our ability to negotiate favorable rates with our pharmacy benefit manager is a direct result of the size and the quantity of spend that the GIC has every year. I see Denise wants to weigh in as well.
I was just going to say what you said, Matt, which is we've seen what happens when we disperse our population across a number of different plans that offer choice. We don't get more competitive, we get less competitive. So working with the PBM, we have the benefit of concentrating all of our non-Medicare members in one PBM, which actually serves to offer the most competitive pricing, believe it or not.
The question actually, I hope you're hearing a theme here in the presentation, that we are focused very much on maximizing our leverage as a payer. I think that is especially important, as Denise notes, in the area of prescription drugs, where we have a market that is dominated by lots of massive conglomerates that are at the top of the Fortune 500, Fortune 10 even, and the pharmacy cost struggle is really best waged using maximum leverage, which is the strategy that we've undertaken. But again, this will be a set of questions that we will seek to address as part of our procurement for plans starting in July 1st, 2023. Great question.
So the next question, are copays still being waived for mental health services? If not, what date did that stop?
So I believe this is probably referring to copays for services delivered by telehealth, and that would include all behavioral health services, but really any services, any healthcare services that you receive via telehealth. We have at the GIC temporarily instructed our carriers to waive all copays for members for those services. This is a measure we took, I want to say back in November, and have suspended copays through the end of March for those services. This is part of our commitment to make sure that you continue to have access to services that you need during all of the restrictions around COVID-19, and which would certainly make anyone hesitant to go into a doctor's office for anything for which they really didn't need to do that. So we will continue to monitor the circumstances on the ground, to borrow a phrase from the governor, and extend that as it seems advisable to do so beyond the end of March. So we are currently in a phase of continuing that through the end of March right now. I believe that's what the question is referring to.
Thanks, Matt. The next question is so the question goes, I have discovered the majority of my physicians, especially specialists, only charge a $20 copay if you see a nurse practitioner instead of a physician. Is this something that you would seriously consider to reduce our copay costs?
Yes, absolutely. We would consider that. Again, I think that is the type of strategy that we would evaluate and consider as part of the next health benefit procurement. what underlies that kind of a strategy is the fact that you have more and more, particularly in the primary care space, non-physician clinicians who are providing primary care services, and they are well within their scope of practice to do so. I see this as a real positive development in Massachusetts. There was recently a piece of legislation passed by the legislature, signed by the governor, that expands the ability of a variety of providers to operate at the top of their license without a physician supervisor. I think it does certainly open the possibility for a way of designing copays that can be the kind of behavior that we would incentivize. So great question.
Okay, the next question is regarding copay and deductibles, because so many services were not used during 2020, surgeries were canceled, and doctor's visits just didn't happen. Will we see a decrease or no increase?
Well, we're certainly at the beginning of that question was about copays and deductibles, and as I noted earlier, we are not making any changes to copays and deductibles, with the exception of telehealth visits for behavioral health. As I noted in the slide around that addressed self-insurance, the fact that we are a self-insured employer, a self-insured plan sponsor, the Commonwealth of Massachusetts ultimately holds the risk. So if we, as a total for the group insurance commission, spend more on healthcare services than has been budgeted and that your premiums were based on, then it's the Commonwealth of Massachusetts that provides that protection for you not to have to pay any additional premium. On the flip side, when claims come in less than are expected, that healthcare utilization is down as it is now, that the Commonwealth is on the hook for less. It's the way we are set up. It's the way we're established in state government. It is not within our power at the Group Insurance Commission to take a different strategy here. But we do work closely with our colleagues elsewhere in state government to continue to monitor all of these trends.
Thanks, Matt. I just wanted to note that we have a lot of questions coming in, and so it is possible that we might not get to all of them, but just wanted to point that out. The next question we have is a little bit more of a comment. As you're considering changes to benefit plans for Commonwealth employees, this individual would like us to consider changing our policy on hearing aids, as the current policy only allows for around $2,000 to $2,400 every 2 years for hearing aids. And most people would require a pair as opposed to just one. And that this individual doesn't think that that would be enough to purchase 2 low to mid-price hearing aids. So just wanted to make sure we address that comment. Matt, if there's anything you wanted to add.
Nothing that I would add. That's certainly an area of our benefits that we can look at more closely. We're glad to do that.
Great. Okay, so the next question is one asking, how do I obtain the details of all Tufts Navigator coverage changes?
So to this, I'd say 2 quick things and do it briefly. One is that there will be no changes other than that those that are laid out here in this presentation as it relates to telehealth visits in behavioral health. And the member can get more information. We will provide, as we do every year, a benefit decision guide and other ancillary materials to help you understand what your coverage options are, and that will include information about Tufts Navigator and all the other plans that would be available.
Matt. The next question is, why don't we have a quote +1 insurance so that a person without children does not have to pay for a family plan if it's just them and their spouse?
Yeah, I think we touched on that with an earlier similar question. So we can go to the next one.
Sure. So the next question is again about the merger. Will the merger between Harvard Pilgrim and Tufts affect us? And if so, how?
Well, I think it will eventually affect all of us. I think the message that I want to deliver here is that there are no immediate or near-term changes that will affect any of our members. They will continue to operate as two separate companies through the next two annual enrollments. You can enroll in or re-enroll in either one of those plans if you're in them or want to enroll in one of them. That said, these are complex transactions, and we will work very closely with the carriers to make sure that there's no disruption for you. I will say in the longer term, through the next procurement, this will mean a change of options. So I would anticipate that the combined entity, whatever it is to be named, would sell one set of plan options as opposed to today where they offer different sets of plan options. My hope is that the combined entity here is able to provide some new additional value to our members. As I noted earlier, as it relates to mergers and acquisitions on the healthcare provider side, the evidence is not great that these things produce savings to members. So the onus will really be upon this new combined insurer to demonstrate to us that they, will be providing additional value. I will say that my conversations with them, they've described the transaction as positioning them well to bring new and innovative approaches to affordability, to addressing behavioral health and particularly integration of behavioral health into primary care, addressing chronic care, the needs of those with multiple chronic conditions. But we will see. I think is the longer term approach here.
Thanks, Matt. So the next question is, I have questions regarding Medicare supplemental coverage. What does it cover and what are the costs for someone with survivor benefits?
For that, I think I'll probably phone a friend, being Paul Murphy, on the my understanding before I turn it over to him would be that Medicare supplement covers what members' liability would be for services that are covered by Medicare, but not 100% covered by Medicare. So that's the real benefit of supplemental insurance. So basic Medicare has a Part B deductible for services that are covered by Medicare, but within the deductible. So a Medicare supplement plan would then cover you for those costs to some degree. Paul, anything you want to add to that?
I would say, Matt, it's true. Medicare has two parts. They often refer to as Medicare Part A and Part B. And when someone goes on Medicare, Medicare becomes the primary payer. Any balance on any claim that is submitted to Medicare that is not paid by Medicare, that's where a GIC supplemental Medicare plan would pick up the balance. So they're designed to supplement your Medicare coverage. As far as the cost for those coverages, the Medicare, we offer about 5 Medicare plans, and the costs vary between carriers. And it is based on things like when did you retire, what is the contribution you pay, dates of retirement also contribute. So the costs vary across the Medicare plans that we offer. I would suggest that anyone who's interested in the actual monthly cost for those plans to check out our website, the benefit decision.
Thank you, Paul. I think we lost Paul at the tail end of that, but thank you,
I
Paul.
went on mute. I was just following up saying that if anyone has any interest in looking at the premiums across all of the plans, to check our benefit decision guide on our website. And that will list all of the costs for all the Medicare supplemental plans that we offer.
Thank you, Paul. I will also note that we have some really terrific resources on the GIC website for those that are turning 65 and becoming eligible for Medicare. So I would encourage folks to access those materials as well. Thanks, Paul.
Okay, the next question we have here is related to turning 65. I turned 65 in June of this year and do not qualify for Social Security / Medicare. How do I proceed?
If there's a way to answer that one, Paul,
Yeah,
here we
sure,
can do that.
I can take.
Yep.
One thing I will tell everyone is that when you are retired and you reach age 65, GIC will reach out to the member and or his or her spouse and ask about their Medicare eligibility. In this case here, where someone thinks that they do not qualify for Social Security, you will have to apply for those benefits directly online with Social Security. Social Security will then send you a denial that you are not eligible for Medicare because you, for whatever reason. That denial is what GIC will need in order to keep you in the current plan that you have.
Thank you.
Thanks, Paul. I just also posted the turning 65 video link in the chat for all attendees. The next question we've got here is, I'm planning to retire in August. When should I contact you and what form should I send in? I think this is very much
Paul.
related.
Yeah, that's another Paul question.
Sure. GIC would make a recommendation that you would at least start this process 2 months before you retire. And we would encourage any employee retiring from the Commonwealth to go through your HR department to inform them of the retirement so they are aware that you are retiring to ensure continuation of coverage. The form.
We lost you again, Paul. All right, thank you. Next question, Erica.
Sure. I think may also be a Paul question. So if we can get Paul back,
I'm here. I'm back.
Oh, okay. Did you want to finish what you were saying on the last question?
Other than for some reason this microphone keeps shutting off, but we just encourage anyone to go through the HR. You can get all the forms you need for retirement through your HR department, and you can start that process 2 months before you retire.
Great, thank you. Another question. I am a survivor living outside of Massachusetts and will turn 65 this year. Who should I contact for more information?
The GIC will reach out directly to you when you turn age 65 with all of your options available to you on the Medicare plans that we offer. So we will reach out to you directly.
Great, thank you. So the next question, if a doctor tells you that you might need surgery, how do we get access to a surgical center? And just a little context here. I remember in a previous GIC session, we were told that standalone surgery centers were better and safer than hospitals. Typically, after we find out that we may need surgery, we ask for a recommendation to a surgeon. We consult with the recommended surgeon, and he or she tells us where the surgery will take place. So how do we get access to a surgical center?
That's a great question. I think the short answer is to be in touch with your with your health plan, with your health insurance company, they will be able to recommend to you a freestanding surgical facility. But this does, the question here underlines the challenge of doing so, which is that, you know, your surgeon will likely direct you to the surgical center that is most convenient for them, but may not necessarily be in your best interest. That's a challenging conversation to have. So I think what I would suggest to someone in that position is that they consult the health plan, get a list of freestanding surgical facilities that would, that, as the questioner notes, are in some cases a better option, and to have that conversation with your physician. But you're armed with a new piece of information that can allow you to have a more informed conversation with your physician. That's what I would suggest.
Thanks, Matt. So the next question is about life insurance. And this individual has paid for increased life insurance from the first day of employment and is facing about double the cost on an upcoming birthday. Can we just speak to why it has gone up? And I think that we had Cameron maybe on deck.
Yeah, I would either Cameron or Denise here on this one. It's a feature of life insurance as we have it set up here. Cameron, you want to take that one?
Sure. Yeah, the voluntary life insurance options, you know, these are what's known as term life insurance. It's not a whole life product where you pay in over time and you have a set dollar amount. They are age banded premiums, and it is a life insurance product that's intended for working age adults to, you know, in the event of an untimely death, that you have expenses that you have funds for your beneficiaries to cover things like putting kids through college, paying off a mortgage. These policies, these plans are not intended to provide, you know, necessarily a nest egg or, you know, estate planning. Otherwise, if they were, they would become prohibitively expensive, and the premiums would be higher for everyone throughout the course of your career. Denise, did you have something else you wanted to chime in with?
Yeah, the only other thing I'll add is that life insurance becomes more expensive as you get older because the chances of you dying and the benefit paying out become greater. So that's why your costs are going up. It's just how life insurance works.
Yep. Okay, thank you.
Thanks, Cameron. Thanks, Denise.
Thank you. So the next question, once a dependent turns 26 years old, are they automatically taken off the health insurance?
Well, they no longer become eligible for it as a dependent. I guess I would immediately, I guess would be a question for Paul, and I see him coming up.
Yes, when a dependent turns 26, their coverage ends the end of the month in which the dependent turns 26, the last day of the month, and they are automatically taking off the health insurance. There is no need to notify us at all.
Thank you, Paul.
Thanks, Paul. Are all new participants eligible for retiree health care?
Maybe that's a Paul question. I'm not sure who would answer that. Is that a Paul question?
Sure, I can.
Thank you.
I'm assuming by new participants, meaning signing up for GIC coverage and getting benefits as a retiree. The eligibility for a retiree to get GIC coverage is that the retiree must be collecting a pension from the state retirement board or a public retirement system, and they must draw a monthly pension to be eligible. So if they meet that criteria when they file for retirement, they are eligible to continue their GIC coverage.
Thanks, Paul. Next question we have, why, for the health insurance, why isn't dental insurance included in it?
That is certainly a possibility. I know there has been, as a result of the Affordable Care Act in the commercial insurance space, so those with private insurance, there's been some movement in that direction. That is certainly a strategy that we could evaluate as part of the next health benefit procurement. And we're happy to add that to the list.
Okay, the next question is it possible to only enroll into a GIC insurance plan for a few months, for example, 6 months, instead of a whole year, if we can get an insurance plan from the spouse's employer?
So I'm going to return to Paul. I think that probably qualifies as if there's a qualifying event, one could change from GIC to another plan. Is that correct, Paul?
Correct. The answer is yes, you can enroll in a GIC benefit if you sign up during open enrollment. And if you have a qualifying event, which is if a spouse has an open enrollment with their employer later in the year, you can sign up and cancel coverage with GIC. Or if in fact your spouse has a new employment and she's eligible or he's eligible for benefits through the new employer, that is also a qualifying event to cancel your GIC coverage. But you do not have to stay on the plan for an entire fiscal year. If there's any questions regarding eligibility, I would highly recommend that on our website, you will find a chart that's called qualifying events, and it will list all of the qualifying events and timeframes needed to make any insurance updates, enroll, or cancel your coverage.
Thank you, Paul. This is an instance too where we have to follow federal law, and so the list of qualifying events is actually codified in federal law. Those are not GIC decisions.
The next question we have is this individual, he and his spouse are both state employees. The spouse carries the family insurance for them and their 2 children. And one of them is contemplating retirement by the end of the year. Is it possible to maintain family insurance as a retiree, or do they need to switch to insurance for the individual? Does it matter? And if so, does that need to be done during open enrollment? Annual enrollment.
That's definitely another Paul Murphy question.
Yes, it doesn't matter. As a retiree, you can continue your family health insurance. One thing to look at is probably the contribution as to what one person is paying as an employee and one person is paying as a retiree. As many of you know, state employees who are hired after 2003 pay a 25% contribution. Anyone before 2003 pays a 20% contribution. All retirees currently, if they retire today, pay 20%. You may want to look in to see if there's any savings on the contribution based on the date of retirement and when you started state service. Bottom line is you can continue your family plan as a retiree. If you decide you want to change that coverage to a spouse's plan, you can only do that during open enrollment.
Thanks, Paul. Out of the 17 members of the commission, how many are voting members?
That, sorry, I was on mute there for a second. They are all voting members.
Thank you. The next question is, I plan on joining the GIC in the spring with a family plan for myself and my wife. If I retire at the end of 2022, am I able to transfer my family plan to a supplemental family plan under Medicare?
I can take that, Matt, if
Yep.
you want.
Please. Yes, thanks.
Yes, anyone that retires from state service who is age 65 or older is contacted by the GIC regarding Medicare eligibility. So if at the time when you retire in 2022, GIC will send a letter to you as a member asking about Medicare eligibility. If you are eligible for Medicare Part A and Part B, when you retire, at that point, you will be able to transfer it to a Medicare supplemental plan.
Just a clarification.
Thanks, Paul. Yep. Go ahead, Andrew.
There is no such thing as a family plan under Medicare. They're individual plans. If they're younger family members, they may have their own policy through us.
Okay, thanks, Andrew. Next question. Is there a limit on mental health services with therapeutic providers for families on a plan?
Can you repeat that, Erica? Sorry.
Sure. Is there a limit on mental health services with therapeutic providers for families on an insurance plan?
I think I would have to ask Denise that question. I don't know the answer to that. I can't think that there are any limitations. What the mental health parity law applies here, and to some degree, which is that you can't have limitations on coverage for behavioral health services that are less generous than similar coverage for non-behavioral health medical and surgical coverage. So I would say that generally about any limitation on coverage, whether that's cost sharing or administrative services or prior authorization protocols, anything like that, they can't be any less generous on the behavioral health side than they are on the medical and surgical side.
Correct. And there are no limits.
Okay, so another question is, why will this procurement be different than the last procurement when all of the recommendations of the GIC were supported and later overturned?
It's a very good question. And I would, I guess I would go back to our strategy of engagement, which is that we intend throughout this process to communicate as much as we can, to hear and listen as much as we can. I would encourage those who, which I assume is everyone, who have a viewpoint and an interest in how that procurement plays out, to communicate with us directly, to look for more opportunities that we will provide to gather your input. My hope at the end of the day is that we put forward a recommendation for our commission's consideration for the next procurement that that takes into account as much as we can learn, right? I will say though that the equation has to sort of balance here, right? That we have to come up with strategies, creative as creative as we can come up with them, to get at the underlying cost of care here, and that we will balance all of the various competing objectives that we have through that next procurement. That sounds a little not particularly coherent, but I guess I would say we're trying to do things a little bit different this way through. My hope is that by the time we have a full discussion with the commission and a recommendation on how to proceed, that those who are following along won't be surprised by the proposal that we put forward. We are constrained, as my predecessors were constrained, by our procurement law, which makes it really difficult at a certain stage in the process, once that formal procurement begins, to be as communicative as we would like. So that is a real challenge that we face, but it is a reality that we have to deal with. I would say that we're going to do our best to put forward a proposal that that the commission will see as, and members will see as, the best possible solution to the challenges that we face. Not a lot more that I can say than that, I think.
Thanks, Matt. So I think
It's a very good question, though.
so. I think we probably have time for a couple more questions. So one, how can we determine if our doctors are in our plans?
I would direct people to their health plan directly. Each carrier has an online tool, which the state has required them, actually federal law requires them to provide, that is essentially a provider directory for a whole range of services. So that is a tool that you can use, each of you can use. I would also encourage members to be in contact with the health plan. As somebody who once worked at a health plan, I know that there's a great deal of insight that that some of those staff can provide. I think that is particularly true as it relates to behavioral health services. There has been, again, some really thoughtful policy and regulation put in place to make sure that those directories provide adequate information for consumers, particularly in the behavioral health area. So that's what I would recommend, is use those online tools and be in touch with your health plan directly. Erica, do we have more? Oops. I think we're having some technical difficulties as we.
It looks like Erica dropped out.
Yeah, we lost Erica.
Okay, well, we are 6 minutes shy of 7 p.m.
Matt, this is Mike. I have a couple questions that are still coming in here on the Q&A.
Okay, great.
Question here is, if we are self-insured, how come we have so many health carriers?
We contract with, it's a good question. And it gets to one of the slides that I noted about how we are financed and how our dollars flow. So we contract with health plans really to provide the member-facing support that you need, rather than us trying to recreate what a health insurance company would offer to people in the private insurance marketplace. They have the tools and the member services. They have the ability to process claims. They have networks, have negotiated prices with healthcare providers. So those are all the services that we purchase when we contract with the health plan. But the health plan, as it relates to GIC, is not performing the financial insurance portion of what is insurance. So there's different ways for us to approach this. My sense is that members receive significant value from having our health plans be their primary point of contact on most items that relate to their coverage. But again, that is not cast in stone, and there are different ways that we conceivably could approach this through the next procurement. I hope that's helpful. It's a complicated question, but I think that's the way we generally view it.
Great. We have another question. Denise, I think this would be a good one for you. It's a procurement question, and I think would be a good opportunity to provide some further insight into that process. Why hasn't the GIC looked into Blue Cross Blue Shield?
We have, and they have not chosen to bid on our population. We will see if they do this time.
Yeah, it's a good point. We again, through the procurement process, we put out a bid and we describe to all the vendors that are out there, including the 6 that we have today, but any insurance company that's out there that wants to participate in GIC, we can't require them to, but they as private entities decide whether they want to be a partner of ours through the GIC.
Great. And I have what might be our last question of the evening. It sounds to me that those of us that live in Western Mass are disproportionately affected by the fact that people in Eastern Mass go to hospitals and doctors who are much more expensive than those doctors and hospitals in Western Mass. Am I interpreting this correctly? ?
It's a really good observation. So I think there's some merit to that argument. I would say, however, that Eastern Mass is not the only place where we have expensive healthcare providers. There's a good deal of state data now that shows that it's not only sort of Boston-based academic medical centers that have significant market leverage to force high prices. There are also some hospitals in different areas of the state, if they are if they're really kind of the only game in town, really the only hospital that people have access to, that they also have significant market leverage. So there is some element of truth to what that individual asks, but it may not be, it's not quite as simple as that. There are other reasons that a hospital could be high priced. So it will be interesting to see what data shows about what our data shows about that dynamic. I will take this opportunity to note that we at the GIC are really investing quite a bit in our data analytics capabilities. We have a very accomplished data professional on our team here. We have moved to a new contract with a different company to house our data, our claims data, that will allow us more sophisticated analytical capabilities to answer these kinds of questions, and then therefore to develop really informed strategies as part of our next procurement. Denise?
I'll say that, yeah, I just wanted to add that we do offer plans that are specific to people in Central and Western Mass, and those plans reflect the costs associated with that coverage.
Yeah, it's a very good point. Thank you.
So my internet is back just in time, and I think that's all we've got in terms of timing for questions. What we will do is, as Matt mentioned, pull all of the questions that we did receive today and weren't able to get to and put them in an FAQ document that we'll share.
Terrific. Thank you, Erica. Thank you to my team at the GIC, and really, most of all, thank you to all of you GIC members who took the time in an evening to engage with us, to hear from us about what our plans are for this year and for the next few years. I will say that the response to these sessions has been overwhelming, and that is a really good thing. I think these sorts of virtual sessions we will continue even post-pandemic, because I think we're seeing that our ability to engage directly with you is greatly enhanced by this. But as I've said, and maybe I'll close on this comment, we are only as good as you can help us to be, and to help us understand what kinds of benefits, what kinds of priorities you have. So stay engaged with us over time, and look out for more opportunities for you to do that. So with that, I want to thank everyone, ask you to please be safe, be healthy, follow all the public health guidelines around COVID-19 so that you can remain healthy, and please reach out to us at any time. We have a very dedicated operations team here to work with you, help you understand what benefits you may need and steps you may need to take. So thank you all, and have a great evening.